So good evening all. At the outset, I would like to thank Pushpanjali Medical Center and Dr. Vanessa for inviting me and giving me this opportunity to talk on a very important topic, blood components and their clinical indications or rational use of blood and blood products. Now first coming down to the introduction. Now all these blood and blood components are defined as drugs as per Drug and Cosmetic Act. So we should use them very judicially because as all drugs do have side effects, the blood components also do have side effects. Now the transfusion of the blood cell nowadays is also called as transplantation because the cells that we are transfusing to the patient, they must survive and function after transfusion in order to have a therapeutic effect. And the main aim of any blood transfusion service is to provide the effective blood and blood products which are as safe as possible and adequately meet the patient's need. So now why blood components and not whole blood? Now earlier we used to transfuse lots of whole blood components, but now slowly and steadily most of the blood centers, most of the hospitals, they are moving from whole blood to the blood components. Because when we are using the blood components, there is optimal survival for each component. For example, the platelets have got a shelf life of 5 days. Red cells, depending upon the anticoagulant, they range of shelf life of 35 to 42 days. FFP can be stored for 1 year. Then transfusion of the specific blood component which patient needs. So if the patient is having low hemoglobin, so why to transfuse whole blood? Why not transfuse only red cell? If there is a dearranged PT, INR, then why not to transfuse only FFP? So it's avoid use of unnecessary components which could be contraindicated to the patient. Several patients could be treated with one component, and supplement blood supply adds to the blood inventory. For example, if we are having 3 units of whole blood, then we'll be having just 3 units in our inventory. But if we are using blood components of platelets, plasma and red cells, we'll be having 9 blood components. So it adds to the inventory. So whole blood, I'll go into the shortage because most of the things will be covered by another speaker. So whole blood is just 350 to 450 ml of blood where the components are not separated, hematocrit of 36 to 44%. So we should never ask for fresh whole blood because after storage of 24 hours and at 2 to 6 degrees centigrade, platelets are non-functional. Factor 5 and 8, which are heat labile factors, they decrease with the storage. There are chances of fluid overload and their highest number of leukocytes or the WBCs, which are the major culprit of any transfusion reaction. Method of separation is simple on the basis of centrifugation. On the basis of the specific gravity, all these 3 main blood components are separated. Red cells having the highest specific gravity of 1.08, they settle down. Plasma being the lowest 1.02, they are at the top, and in between they are the buffy coat which comprises of platelets and the white cells. Packed red blood cells, approximately hematocrit of 55 to 65%, and as I mentioned, depending upon the anticoagulant, they have got a shelf life. Like if we are using only CPD, it's 21 days, CPT-A1 35 days, and Adsol 42 days. Now the most important thing, what is the recent guideline of transfusion of red cell? Now as per the WHO and recent guidelines, hemoglobin level of less than 7 grams per deciliter justifies a transfusion. And for stable patient, if the hemoglobin level is between 7 to 10 grams per deciliter, then the benefits of transfusion is still unclear. But it is also important to not only look at the hemoglobin level, but also to see the cardiac output, volume status, and the patient history. Now this chart is very important. So as we all know, the ORH negative is a universal donor for the red cells. So it can be transfused to any patient with any blood group, whether positive or negative. So obviously the first choice is the group specific, and the second choice is the O negative. For O positive can be the universal donor for all the positive patients with blood group. So it can be a second choice, but ORH negative definitely can be transfused in cases of emergency to any blood group patient. Coming to the platelet concentrate, so we all know there are 2 types, random donor platelet RDPs, which has a volume of 50 to 90 milliliters, stored at a room temperature, having a shelf life of 5 days. And I'll come to the chart on this. And the single donor platelet, which are obtained by a process, specific process, which we call it as apheresis. So apheresis is done by a special equipment which we call it the cell separator, which has the ability to separate any cell line. Means we can separate the red cells. If only the red cells are required, we term it as red cell apheresis. If only platelets are required, we can just extract platelets. It is called as platelet apheresis. Similarly, plasma and plasmapheresis. So the main difference between RDP and SDP is that the SDP volume is more. It's 6 to 8 times, volume is 200 to 300 milliliter approximately, and there is a rapid increase of platelet count of 30,000 to 60,000 as compared to the RDP. That's why these are more preferable in cases of severe thrombocytopenia, especially when the platelet count goes below 10,000. So as per the international guidelines also, the WHO says that the platelet transfusion is recommended with a trigger of 10,000 per microliter. Above this, it is not recommended, but of course, we have to see another clinical parameters also if there are any sites of or clinical signs of bleeding. Now, this chart is very important for platelet concentrate. There's a lot of confusion. So just like red cells, the ORH negative was a universal donor for all the blood group patients. Here, it's AB group, which becomes a universal donor. Now, why AB group here? Because platelets in plasma, they are defined by the presence of antibodies. And these antibodies are present in the plasma. All the antigens are present on the red cell surface. So if there is a AB group, it means both the antigens are there on the red cell surface, and as per the Carl Snyder law, so all the opposite antibodies are present in the plasma. It means if both the antigens are there on the red cell surface, they won't be having any antibodies. That's why these AB group becomes a universal donor. So we can, for all the blood group patients. So that's why we can give them in cases of emergency also if the patient's blood group is not known. So AB becomes the first choice in cases of trauma patients, in cases of massive transfusion patients when we are not even aware of the patient's blood group. Of course, the blood group specific is the first one. For example, if the patient's blood group is A, definitely we'll give the A group, and second choice will be AB group. Another important factor over here is that RH factor does not play any role in the platelet transfusion because RH factor is present on the red cell surface. So opposite antibodies are there in the platelets, which hardly matters. So irrespective of the RH factor, we can transfuse platelets, but of course, if the volume of the, because the volume of the random donor platelet is very low, so we can transfuse across the group also, but it all depends, there should not be any red cell contamination. But obviously, the first choice is group specific, second choice is AB group, and then third choice is that we can give them across the group only random donor platelets, but not the single donor platelets, because single donor platelets have got volume of 6 to 8 times that of a random donor platelet. Next, coming to the fresh frozen plasma. So it's prepared from blood within 6 to 8 hours of donation and mainly given when there is a dearranged INR value and more than roughly 1.5 times that of the normal PTA and BTT, and the dosage is 10 to 15 milliliter of kg of FFP. So now here, this chart is same as that of the platelet transfusion because here FFP are defined by the presence of antibodies. So again, the first choice is the group specific and the second choice is the AB group. And here also RH factor will not play any role because RH factors are present on the surface of the red cell. So it's very important to remember that ORH negative is the universal donor only for the red cells, but not for the platelets and plasma because O group platelets and plasma will be having both the antibodies which can hemolyze the red cells of the patient. So in cases of platelets and plasma transfusion, AB group becomes a universal donor because AB group will be having no antibodies in the platelets and plasma because both the antigens are present on the red cell surface. So in cases of emergency, for example, we are having an active massive transfusion protocol. If we anticipate any trauma patient is coming, so we activate massive transfusion protocol where we give 4 units of ORH negative red cells, 4 units of AB group platelets and 4 units of AB group plasma, whether the blood group is known or not known. So that's why these become the universal donor for plasma. Then there is a cryoprecipitate, which is rich in factor 8, von Willebrand factor and factor 13, mainly required for gastrointestinal patients which are having dearranged INR or in cases of liver transplant patients. Then another important aspect I like to cover is the leukodepletion. Now we have moved from whole blood to blood components, but it's very, very important that we also remove the white cells because these white cells are the major culprits of any transfusion reaction. So these can cause HLA aluminization, they can cause viral transmission of CMV, EBV, HTLV1, HTLV2, they can cause immunosuppression, and also reactions are very common such as graft versus host disease. So leukodepletion is the most advanced method of preparing the blood components, and there are various methods, but the most advanced method is by the specific leukodepletion filters. And here again, the filters are of mainly 4 types, the first generation, second generation, depending upon how much WBCs can be removed. For example, in our center, we are using 4th generation filters, which have the capability of removing 99.999% of the WBCs, which are very safe, especially for those patients who are immunocompromised, for transplant patients, oncology patients. And just to give you example that we are doing 3,000 transfusions in a month, and our reaction rate is once in 3 months. That is, we are getting just one reaction out of 9,000 to 10,000 units that are being transfused. And this reaction, that too is with the platelets and plasma. We have not even witnessed in last few years any reaction with the red cells. Why? Because we are using leukodepletions. We are removing the white cells approximately by 99.999%. And for transplant patients, in addition, we are also doing irradiation. So the remaining 0.01 to 0.001% WBCs are also inactivated. So that are more safe for the transplant patients. So next, one more slide I like to add, that as for SDP, I have told you that because the volume is more, the single donor platelet volume 6 to 8 times that of the random donor platelet. So group specific platelets are required. But we have got a specialized technique which most of the centers they are using by additive solution. So as I mentioned in my lecture, that platelets and plasma are defined by the presence of the antibodies in the plasma. And with this technique, we are removing the entire plasma and adding the additive solution. So we have done approximately 8,000 procedures with the platelet additive solution in last 10 years. And we have not encountered even a single reaction. And this is FDA approved and most of our DCGI approved. So most of the advanced centers, most of the tertiary care centers, they are using additive solution. So the advantage is that, especially during the dengue crisis, the patient has to not run for searching of a group specific donor. Even all the groups, for example, if they are doing the SDP with the additive solution, they become the universal donors. So A group SDP can be transfused to B group, similarly O group SDP can be transfused to any group. So this is a very innovative technique and mostly used in nowadays in the tertiary care centers. Apart from that, it also helps in preventing severe allergic reactions and even TRALI. Then the last slide regarding the hematopoietic stem cells. So we are also doing, this is another blood component which we have, which is being extracted in most of the advanced centers. And this is called as the PBSC or the peripheral blood stem cell harvest. We have approximately done 200 procedures of the bone marrow transplant, and we are doing this peripheral blood stem cell collection, which is a very innovative technique. And it is also requires a specialized machine, which is again a cell separator, but it helps in all sorts of oncology patients, especially it's very good in multiple myeloma and other cases of blood cancers. Now coming to the future prospects of blood donation, now recently I went to a conference and there was a speaker, international speaker who gave a lecture especially on the artificial blood. That soon after, maybe after 5 to 6 years, donors will not be required for any blood donation because artificial blood is soon coming. And just like by putting the ATM card, we get money. Similarly, we can get the artificial blood of any blood group across the machine. And these are entirely produced by the artificial methods, by artificial proteins. And these are the stage 4 trial is being under process. And he told that in next 5 years, it will come into the place into the market. And again, the advantage of the artificial blood is that it will be reducing the dependency on the blood donors. It will eliminate the risk of contamination, universally matched to all the blood types. Because it is artificial blood, so no need to match red cells, no need to match platelets, no need to match the plasma. And longer shelf life than natural blood, quick and effective response to mass trauma patients, accessible to patients in rural areas, and enable blood centers for countries who cannot maintain even the natural blood center. So, but right now, the most important thing is that we have to ensure that the right patient is getting the right product at the right amount, at the right rate, and at the right time. Thank you so much. Thank you for your time.